Good morning. My name is David Myers, class of '96. I'm the immediate past president of the Alumni Association. I'm a member of the planning committee for this, and currently I'm also chairing our strategic plan committee. Our next panel is going to address a very serious issue affecting the globe, the rise and spread of antimicrobial resistance in microbes. Each year, approximately 700,000 human deaths are attributable to antimicrobial resistance, or AMR, and if trends continue, an estimated 350 million cumulative deaths will be caused by AMR by 2050. Without breakthrough research and interventions, we risk an unthinkable return to an era of untreatable infectious diseases. As a global leader in the fight against infectious disease, Tufts is responding to this threat by establishing the Tufts Center for Integrated Management of Antimicrobial Resistance to combat AMR infections. The Center's faculty members who have joined us today are just a sampling of the interdisciplinary scholarship taking place across our campuses. I'd like to introduce our moderator, Dr. John Leong. He is the Edith, Rieva, and Hyman S. Trilling Professor of Molecular Biology and Microbiology and Chair of the Department of Molecular Biology and Microbiology at the Tufts University School of Medicine. Please join me in welcoming Dr. Leong.
So I am also the father of a freshman, and I have to say I was in a meeting, an institutional biosafety committee meeting, when I got a text from him as a senior saying he got into Tufts. And so luckily I was sitting down so people couldn't see that I wet my pants. The first thing I did was I texted my wife. First I said, "Oh, that's fantastic, congratulations, Tim." And then I texted my wife separately, "Dear God, please don't let him flunk out." So I'm actually going to meet him here, and I'm now an official Tufts parent. Yeah. So I hope we have an interesting panel for you today. We now have 4 speakers, and it's Helen Boucher, Caroline Jenko, Amy Pickering, and Bree Aldridge. And we're going to go successively, and Helen Boucher will go first. And she is an internationally recognized leader in AMR and consults regularly with companies, small and large, who are in the development of antimicrobial drugs. She also consults with the FDA. She's on the faculty of the Tufts Center for Drug Development, which investigates policy issues, financial issues, incentives, as far as trying to develop drugs for the marketplace. So please welcome Helen.
Thanks very much, John, and thank you so much for having me with you today. And I'll tell you my personal Tufts undergrad story. My godson came to visit us last night from St. Louis, and he's touring Tufts today as a lacrosse potential recruit. So we're very excited for him, which is great. So without further ado, I'll talk a little bit about our collaboration in combating antimicrobial resistance, or AMR, and I'm going to try very hard to avoid too much alphabet soup this morning. As John mentioned, I work at the medical center, and I've been there since 2002, and I take care of patients every day. So I thought it would be useful to start our discussion with a couple of patient stories that kind of exemplify where we are today in the crisis of antibiotic resistance. And in fact, the first case I'm going to tell you about is a lady we took care of several years ago now, and I think one point to make is that while the sort of attention on the crisis is higher today than it was 10 years ago, we've been focused on this problem at Tufts for over 15 years, actually going back to 2004. And this lady I'll tell you about is a 71-year-old lady who had cancer of her larynx, or her voice box, that was cured with surgery and chemotherapy and radiation. So she had lived through a really near-death experience from the cancer. And she came to us several years later with bronchitis, a lung infection, but also with fever and pain in her back, suggestive of a kidney infection. And she actually had bacteria in her blood and her lung that proved to be a multidrug-resistant Klebsiella, or gram-negative bacteria. And we gave her 3 different drugs at that time, a combination of drugs, because that's what we had to do to combat this infection. And she got through that. A year later, she came back with sort of a similar bad kind of near-death experience. This time, the organism was resistant to the most broad spectrum class of drugs that we had at the time. And in fact, it was resistant to all 17 drugs that we tested in the lab. So we got back a report, we get back sensitive, intermediate, resistant, it was just all ours. And it included resistance to 2 brand new drugs that were developed to combat the most resistant gram-negative drugs. So at this last admission, there was a discussion with our lady and her family to say that we could try further combinations, and we had one drug, kind of this last-ditch drug called colistin, that is predictably toxic to the kidneys and the nerves. We could try that again and would guarantee toxicity, and we didn't have high hopes for her success. So she opted to go on hospice and die, and she did pass away shortly thereafter. And sadly, that story of a patient where we have to tell the patient and their family that we can't offer anything has happened all across our country and all across the globe. That's not something I grew up with when I started back in the late 80s, early 90s, and it's certainly not something we in infectious disease like to do, right? We like to cure people. So that's a very troubling group of patients. I'm going to contrast that with another kind of patient that we see more and more often, actually. This was a young, middle-aged, 47-year-old school teacher who came in with a urinary tract infection, very common infection, and her primary doctor started her on ciprofloxacin, a very common oral drug, and a couple days later she came back sicker, and she had full-blown kidney infection. She got 1 dose of IV medicine that's standard in that setting, and got to go home because she was otherwise healthy and she was still eating and drinking and doing okay. Well, unfortunately, she came back later, more sick, higher fever, actually low blood pressure, quite ill, actually had to get admitted to the hospital, and she had infection due to a gram-negative with extended spectrum resistance, for which we only have IV drugs. So this young, healthy school teacher couldn't teach her class, couldn't be home with her family, had to have a PICC line IV put in for 2 weeks of IV therapy. And today we still have this problem, and we see a lot of young, functioning people taken away from work, education, family duties that have to have these invasive therapies. So this is kind of the face of where we are with antimicrobial resistance, and people ask us a lot, have we returned to the pre-antibiotic era? Is it so bad that we're going to go back to a time when people died routinely of bacterial infections in our country? And I think many of us would say, well, maybe. You know, we have now bacteria that are resistant to everything that we can treat with. We know that some of these resistance elements are transmissible. They can jump between bacteria and patient to patient, and that's pretty scary. And we who take care of these patients are forced to use drugs with limited data to make up combinations which are potentially toxic, and then tell our patients that that's what we have to offer, and we don't have anything else to offer. So we have multiple ways that we're addressing this, right? We do everything we can to prevent infections in the first place, from washing our hands to doing procedures in the best manner possible, to using the antibiotics, the precious few antibiotics we have well, and then doing surveillance to find out what kind of resistance is around. And this problem of AMR has been addressed at the UN. We had a high-level UN meeting a couple of years ago. It's a global problem, and the kind of burden has led to national security and other groups being very interested, and we'll talk a little more about that. In thinking about the problem, it's not just patients in our hospitals, right? We know that antibiotic resistance comes from animals to humans often, right? We're hearing more about foodborne illnesses, and this is from the excellent medical journal CNN a couple of weeks ago, talking about salmonella from chicken in the grocery store, making 92 people in 29 states sick, and this is a drug-resistant salmonella. So it's not just be careful how you prepare your chicken and cook it, because you might get food poisoning. You might get food poisoning due to a salmonella that's resistant to multiple antibiotics, and that's a bigger and bigger problem. So thinking about how we attack AMR is important in that we want to minimize antibiotic use in animals and think about this connection, and we're going to talk some more about that today. So the connection, we know there's a connection of resistance between animals and people, and also the environment and people. And people here at Tufts and all around the globe have done lots of work looking at antibiotic resistance in water, in rivers, in the runoff of antibiotic manufacturing plants. So there is this connection between people, animals, and the environment with antibiotic resistance, and that's we call One Health. And so we know the problem is existent in this manner, and we believe that the solution requires a One Health approach. We need to address all of those areas for this problem. So as John mentioned, the global crisis, the CDC recognized this in their threat report back in 2013. The WHO and others have had similar reports. In the United States, we have a reasonable, I'd say, not perfect, understanding of the magnitude of this problem. The CDC estimated back in 2013, 23,000 deaths per year. That's a very conservative estimate. That's the equivalent of a jumbo jet crash every week. Globally, it's 700,000 by some reports. A book published this week says 1.5 million deaths per year due to AMR today. And the UK AMR review showed that by 2050, if we do nothing about this problem, there'll be over 10 million deaths per year related to AMR. And that's where the national security issue comes in. If we lose that much income generating potential in countries, that will affect the global economy and global security. So what about antibiotics? We take them for granted. We've had them since the 1930s. They're wonder drugs, right? Well, it hasn't been so easy in terms of discovering them, and that's shown in this sort of very classic slide that shows that, up until the 70s, we had pretty good progress developing antibiotics. And then we had really a 4-decade drought, especially in the area of gram-negatives. Those infections I told you about were both caused by gram-negative infections. So we at IDSA, the Infectious Disease Society of America, and others got involved in sort of shouting out the cry for work in antibiotic discovery and development back in 2004. And there's a little bit of good news that's shown in this chart, where you can see the decline in antibiotic approvals going back to 1983, and then a little bit of an uptick in 2013 to 2017. So that's a little bit of good news. We issued a cry back in 2010 for 10 new systemically available antibiotics by the year 2020, and wrote a lot of papers and made a lot of noise in Washington and other places about this. And the good news is we have 10. The 10th antibiotic just got approved by a company called Paratech that actually grew out of Tufts and Stuart Levy. And so that's really good news, and I think some of these antibiotics have already helped our patients. The bad news is that none of these antibiotics address all the problems. They don't address the problem of our First Lady, and they don't address problems in our hospital this week. The further bad news is what's going on economically. This is showing the stock prices for all the late-stage antibiotic companies over the last 18 months. So despite those successes I showed you with the approval of antibiotics, the stock prices have gone down, and companies are firing their research and development groups, and we're seeing further exit from this space, which is very, very concerning, and leads to the need for incentives for antibiotic drug development that John alluded to, that our work is very active in now. And so the idea is that we have incentives for people to both discover these antibiotics, so-called push incentives to get them into the clinic, to get them to our patients, and then pull incentives to keep them on the market. And so there's a lot of work going on within the government. Scott Gottlieb, the head of the FDA, has called for incentives recently, which is very unusual for somebody at the FDA to do that. And we're very engaged in the science of how these would work, and the concept of delinking an incentive, delinking the use of antibiotics from the sales, right? We know that overselling, overusing leads to more resistance. So is there a way by which someone could make enough money for developing antibiotics without overusing and overselling? So that brings us to stewardship and using our antibiotics well. The idea is to use them as best as we can for every individual patient that we treat, as well as for overall healthcare outcomes. And we at Tufts have had a stewardship program since 2002, over 15 years. We were really early to start this sort of type of medicine. We have a dedicated team, and we've sort of helped lead the charge. We're a CDC Center of Excellence, and we have one of the first CDC LEAP fellows and residents at Tufts as of this year. So we were working very hard on multiple ways to preserve the effectiveness of the antibiotics that we have via stewardship, and in our center we'll be working in this area as well. So where are we with antibiotic resistance? I think one of the most important messages I can leave you with is that the crisis has arrived. I was at a meeting in Washington with the GAO office thinking about some funding for this area, and one of the people at the table, very high up in this organization, made a comment during the day and said, well, when it gets really bad, then we can think about something. And I think if I can leave you with one message, it's really bad. We are there. We have patients. One of our fresh heart transplant patients required very toxic antibiotic this week because the infection that they had is resistant to everything that's non-toxic. And we don't want to see that, right? The precious resource of a donated organ. It is a national and global health security risk. I hope I convinced you of that. And it requires a One Health approach. We need to address it in our patients, in animals, whether they be farm animals or companion animals. We're actually doing studies of transmission of antibiotic resistance from companion animals to people and back, our dogs, our cats, and then in the environment in multiple aspects. So with that, I'll thank you very much and look forward to our further discussion. Thanks.
So thank you, Helen. So our next speaker is Caroline Jenko. So Caroline has a long history of work in bacterial pathogens and particularly interested in chronic infections and how they affect our systemic health. She is chair of the immunology department at the medical school and a very energetic academic leader, and I can brag about her because I chaired the search committee that recruited her, and I hope she's forgiven me since that time. And so, Caroline, please come up.
Thank you, John. I might walk up around. Can I do that with this mic? Can I do that? I just can't stand standing behind a podium. Let's see, did I do something wrong? Okay, so we have been interested in, for a number of years, actually my graduate work many years ago was focused on sexually transmitted diseases. And the problem that I studied many years ago, believe it or not, was antimicrobial resistance in strains of Neisseria gonorrhea, which is the bacteria that causes gonorrhea. And so that was a long time ago. We were studying how plasmid DNAs transferred antibiotic resistant genes among strains. And so, as Helen said, the problem has really not gone away. I would not have thought that I'd be still working on this many years later. So we are really interested in trying to understand the disease in humans. Many people work in the laboratory and in animal models, in laboratory models, but we really want to understand what goes on during human disease. And so we have been working particularly with a cohort of subjects in China, and I'll tell you why China, looking at transmission of antimicrobial resistance genes in gonorrhea. And so Neisseria gonorrhea is one of those organisms that Helen talked about that in 2013 the CDC indicated was one of the 3 top urgent threats. And so we have been studying in particularly a cohort of subjects in China. And the reason China, 1, because we have so much disease in China, and 2, because we have so much antimicrobial resistance in China. So the CDC just put out a report last month looking at the cases, this is in the United States, of sexually transmitted diseases. And what they reported is that we're experiencing a very steep, sustained increase in sexually transmitted diseases. And these are looking at numbers between 2013 and 2017. There's been a 31% increase in the total number of bacterial sexually transmitted diseases in the U.S. alone. And of those, the cases of gonorrhea have increased since 2013, 67%. And actually syphilis is a huge problem, and congenital syphilis is actually a huge problem. And so one of the problems with many of these sexually transmitted diseases is that if you don't treat them, they can really lead to severe health problems. So it's been shown that the diagnosed cases of these STDs only represent a small fraction. So although the CDC is reporting increased numbers, that number is probably 2 or 3 times much higher because so many cases go undiagnosed. And if you don't diagnose these STDs, you get severe secondary complications of the infection, including ectopic pregnancy, infertility, and increased risk of other STDs. So as I said, we have been interested for a number of years in gonorrhea, the disease caused by Neisseria gonorrhea. And worldwide, although there's also been an increase in the U.S., worldwide, every year there are about 100 million cases of gonorrhea. And in particular, there's been an increase in antibiotic-resistant strains in the U.S. and worldwide, and in particular, the Western Pacific region where we are studying antimicrobial resistance. Now, one of the interesting things about many of these sexually transmitted diseases is that the disease is very different in men and women. And so typically men who are infected are symptomatic, and so they go into their primary care provider to be treated. Women, the majority of the time, are what we call asymptomatic. They don't have symptoms. And so they don't get treated because they don't know that they're actually infected. And so, and the reason is that in men, you get a lot of inflammation, which leads to the symptoms. But in women, you get a very low-grade inflammatory response, so you don't know that you're infected. And so these asymptomatic infections in women can lead to something that we call pelvic inflammatory disease, which leads to infertility and actually transmission of other sexually transmitted diseases. So we're really interested in why it is that women are asymptomatic. And we're particularly interested because we know that gonorrhea disproportionately affects women and neonates. As I said, it can affect fertility and reproductive health, pelvic inflammatory disease, infertility, and ectopic pregnancy. Maternal gonorrhea can actually lead to premature rupture of membranes, low birth weight, and miscarriage. And then in neonates, it can also lead to conjunctivitis. So it is particularly a problem for women and neonates. And as I said, one of the biggest issues for us now in the disease is that gonorrhea is really expected to eventually wear down our last effective antibiotic. And there are a number of new emerging antibiotic-resistant genes. And now the Centers for Disease Control is recommending a 2-drug combination. That's because one drug alone doesn't do the trick. So we are really interested in how this happens during natural human disease. And so we went to Nanjing, China, where we have been studying a cohort of subjects attending a sexually transmitted disease clinic. And the reason we went to China was, 1, because there's lots of disease there, 2, because there's antimicrobial resistance there, and 3, because we could really study asymptomatic disease in women there. And so the design of our study is that men come into the clinic with symptoms, they're infected, and they're enrolled in our study if they have more than 2 sexual partners. So the particular cohort that we're studying are particularly married men. They get the disease from their mistress, and then they go on to transmit it to their self-reporting monogamous wife. Okay? So we're really interested in the wife who has the disease. So the men come into the clinic, we then contact their wife, and they come into the clinic. So she would be the asymptomatic female, and what we get is a specimen from both the male and his matched partner. And we take that specimen, and it's actually shipped to us here at Tufts, and we do something called RNA sequencing, where we sequence the RNA in that specimen. And that specimen contains RNA from the host, from the human, and the microbe. And so what we're doing is we're analyzing how these genes are expressed during an active infection in a male and his matched partner. And so what we've started to uncover in this analysis is there's gender-specific gene expression of these antimicrobial resistance genes during infection in men and women. And so this is just a little diagram of the bacteria as it's growing in vivo. And what we showed in a study that was recently published is that while the men and the women have the exact same bacterial strain, okay, with the exact same genes, the expression of those genes are much different. And so in men, you actually have 4 times higher expression of these antimicrobial resistance genes than in women. And so how do we interpret this data, and what are the implications for future studies? And I should just say that this is the same slide that Helen showed, and this organism right here is Neisseria gonorrhea. So what we think is that therapeutic strategies, that is prescribing specific antimicrobial agents, could be targeted to sex-specific differences in expression of these antimicrobial resistance genes. So what I mean here is that you might prescribe a different level or a different antibiotic to a male with the disease versus a female with the disease. And so we're continuing these studies. We're currently enrolling another 144 subjects, and we're starting to look at other sexually transmitted organisms. It's in most of these STDs, you're typically infected with more than one. So many of these patients who have gonorrhea also have chlamydia, which is also a common infection. And so we're now starting to look at potentially the differences in antimicrobial resistance genes when you have more than just one infection. So thank you very much for your time, and look forward to a discussion after all the panelists.
So our next speaker is Amy Pickering. So she's a recent addition to the Civil and Environmental Engineering Department here in Medford. She trained at Stanford University's interdisciplinary program in environment and resources and has more than 10 years of experience of conducting environmental health research in low resource countries. I actually met Amy probably a few months ago when she was instrumental on the committee to actually form the Center for Antimicrobial Resistance, which I'll be discussing a little bit later. Amy.
Hi, everyone. So as an environmental engineer, I'm studying the problem of the spread of antibiotic resistance from a different angle, the role of the environment. So one of the main ways that antibiotic resistance spreads is through the transfer of antibiotic resistance genes from sometimes benign bacteria to pathogenic bacteria in the environment. And so this often occurs in the environment where you have high concentrations of bacteria, such as in wastewater treatment plants or sewage, and you also have selective pressure from antibiotic drugs being flushed down the drain, or other mechanisms of compounds getting into the environment. So this picture on this slide is actually from Dhaka, Bangladesh, which is one of the field sites where my lab does work. And low-income cities around the world where you have really poor sanitation facilities in place and also unregulated antibiotic usage, they end up being hotspots for the emergence of new strains of antibiotic-resistant bacteria. So in Dhaka, we have 98% of human waste, sewage, flowing into the environment without any sort of treatment. At the same time, antibiotic drugs are very, very easily procured at local pharmacies without any prescription. So it's very, very easy to just buy antibiotic drugs whenever you feel like you need them. And so I'll talk a little bit more about what we're seeing in Dhaka in a second. But I did want to mention that when we did a survey of mothers, what we found was that in the past 2 months, 40% of mothers had said they had given their children under 5 antibiotic drugs. So that's 1 in 2 children consuming antibiotics in the past 2 months. So environmental surveillance actually has the potential to be a low-cost way of monitoring new antibiotic-resistant bacterial strains. We don't usually think of sewage as being a very useful product, but actually it's able to concentrate information from local populations and sometimes in low-income countries, information from animal waste as well. So one thing that we've been working on is environmental surveillance for antibiotic-resistant bacteria, and currently there's no standard method that exists that allows for comparison across field sites around the world. So one thing that you can do is sequence all of the DNA that you find in an environmental sample. And this allows you to assay for thousands of antibiotic resistance genes at once, as well as what types of bacteria are in that environmental sample. So our lab has been exploiting some recent advances in portable DNA sequencing technology. So what we're using is a novel handheld device. It's actually smaller than an iPhone, and it's able to sequence extra long strands of DNA. And through passing them through tiny pores called nanopores, and it measures changes in the electric current that tells you, that indicates differences in base pairs in a DNA strand. So this device actually costs less than $1,000, so it allows it to be accessible to many sites around the world. So we've been using this technology in India and also in the Boston area, looking at wastewater samples. And the long sequence reads that we get from this technology allow us to look at what types of bacteria are carrying specific types of antibiotic resistance. So right here we're looking at E. coli found in India in hospital effluent compared to E. coli found in Boston from a hospital effluent. And we see that it carries different types of antibiotic resistance genes. Another topic that our lab is interested in is environmental control of the spread of antibiotic resistance. And so one thing that we're working on in low-income countries is using water treatment, so providing safe water, that has the potential to reduce the burden of disease, but also reduce usage of antibiotics in low-income settings. And so what we found is by providing chlorinated safe drinking water in Dhaka, this has reduced child diarrhea prevalence by about 23%, but also reduced antibiotic consumption of children that are receiving safe water. So what we're doing right now is we're using DNA sequencing to actually look at stool samples collected from children receiving safe water versus unsafe water to see if there's also a reduction in carriage of children having antibiotic-resistant bacteria in their guts. So since I'm an engineer, I'm going to cut it short right there. So there's lots of time for discussion.
Thank you. So our last speaker is Bree Aldridge. So Bree actually is in the microbiology department. She was one of my first faculty recruits when I became chair. She's actually trained in biomedical engineering, and she did her postdoctoral fellowship in microbiology, and that was really her first foray into microbiology. And so when we recruited her to two departments, the biomedical engineering department here in Medford, as well as the microbiology department here downtown in Boston. And so I think she's really fostered, her dual appointment has really fostered quite a bit of cross-campus, cross-disciplinary collaboration. So.
Thanks. All right, let's go for it a little bit here. All right, so I'm here to talk to you about TB. I'm actually going to go to this slide first. So one thing I'm going to tell you about my lab studies tuberculosis. It's caused by an infection with a bacterial pathogen called Mycobacterium tuberculosis. And what most people here in the U.S. don't realize is what a problem TB still is in the world. So it is the leading cause of death in the world due to a single infectious agent. And approximately a third of the world's population is latently infected with TB, right? So that's a massive infection. What I'm showing you here is a picture that I stole from Twitter, and it's unattributed because I don't know who posted it. But it is a picture of all of the pills that are required on the standard TB drug regimen. So if you get TB even here in the US, in the best possible case scenario, you have drug-sensitive TB, so not drug-resistant TB, and we'll get to that. You're going to be on a course of 4 antibiotics for 6 to 9 months. And so this is the shorter treatment course of 6 months. These are the pills you would have to take. So it's really a massive amount of pills. And this treatment regimen has not been shortened in about 50 years. Okay, so as John said, I'm an engineer. So instead of thinking about how we can do this from a molecular level, I sort of stepped back and analyzed at first principles what causes this problem. So why is it that we need multiple drug treatment to treat TB for such a long period of time? And then can we dissect that and intervene in places that we need more studies? So the first reason why we need to treat TB with multiple drugs, as both Caroline and Helen suggested, is that it is to slow the acquisition of drug resistance, which is a major problem in TB as well. The second reason is because the drugs we have aren't particularly great. So if we combine drugs together, we have a better chance of having an effective drug treatment for TB. The third reason is one that I think is important, very important and understudied, is that TB is inherently a heterogeneous disease, meaning that when you treat somebody with TB, you're not treating a homogeneous population of bacteria, you're treating somebody with different lesions that are created in the lung over the course of the lung infection. And each lesion is independent and separate from each other. And they give different pressures onto the bacteria, which means the bacteria in each lesion respond differently to each drug treatment. So you need to use a combination so that you have an effective therapy against every single different kind of bacterium in that human. Okay. So, but the way we design drug regimens in TB and actually in the antimicrobial space together is to think about one drug at a time and then to randomly mix them together, right? So we need to use combination therapy, I've just told you that, but we don't design therapies in combination, we design them as monotherapies, right? So has anyone here taught a child how to cook or had a kid come into the kitchen and say they want to cook a meal? All right, and so what do? They're gonna put on the table in the kitchen, your kitchen island, they're gonna plop down their very favorite ingredients, right? And you know as the parent who has a lot of experience in combining ingredients together that combining these things together may not always be a good idea, right? So what I'm showing you on the slide are 3 of my very favorite foods: dark chocolate, salt, and garlic. Okay, so we know that they're good on their own, right? At different doses, of course. We can combine them together, and sometimes that's excellent, and we get a synergistic pairing of individual ingredients that we already know we like and are well tolerated in the body, and sometimes the pairing is horrendous and makes each element worse than it was on its own, right? So chocolate and salt is a fantastic pairing. Salt and garlic is a fantastic pairing. Garlic and chocolate, not so much, except maybe in the case of mole sauce, right? So this idea of how do you combine ingredients is the exact same problem that we face in designing multi-drug treatments for TB and for other pathogens, and also in cancer biology. So this is not unique to infectious diseases. All right, so what we want to do here is see if we can get beyond looking at drugs as monotherapies and designing the best regimens in combination, right? So in order to do that, we have to actually sample how these drugs behave together, right? Because a kid doesn't know which of their favorite ingredients aren't going to go together without first sampling them. Okay. So the way we typically do this is called a checkerboard assay. So what you see on the left is a grid of one drug against another. And what we do on the grid is we do increasing doses of one drug plus increasing doses of another. So down in this corner is low amounts of drug X and drug Y, and up here is high amounts of both drugs. And the way this assay works is we put those drugs together. We put, in this case, bacteria in the different wells, and then we assay to see how well that drug combination kills the bacteria, right? In the case that the 2 drugs act in an expected way together, so that could be lettuce and tomatoes, right? Those are not synergistic, they're additive, right? They make your salad as good together as you would expect from eating lettuce or tomatoes alone, right? So in this case, you're going to have a straight line go across here. So the activity of the drug X and the activity of the drug Y are going to be in a straight line. If you have a synergistic pairing of drugs, meaning that the 2 drugs are more effective together than they are expected to be based on their behaviors alone, so the pairing of making pesto, for example, you're going to have a synergistic behavior, and you're going to get a contour on your diagram that's concave. In the case that you have an antagonistic interaction, so the drugs make the other drug work worse, you're going to get an antagonistic interaction, and that's going to be a convex shape. Okay, so this is commonly done. It's been done for many decades. And the problem with this is that it works fine if you're measuring drug X against drug Y, but if we want to survey the combinations of all possible drugs, then we have a problem with our experiment, right? So if I'm going to measure 2 drugs, it's going to take 1 microtiter plate. So this is not a big deal to look at in the lab. If I study a 3-way interaction, I need a stack of 3 plates, each with 384 wells inside. So that's kind of a pain of an experiment to do, but it's definitely possible. Remember, the TB drug regimen is 4 drugs. So if I'm going to measure how those 4 ingredients act together, I need a stack of 25 384 well plates to measure that. And for this reason, these measurements are not made. So this is why we have an ad hoc approach to designing regimens. And by doing that, we're leaving the full potential of each of the individual precious drugs we have on the table by not really accessing which combinations are going to be the most effective in patients. All right. So as an engineer, we kind of took a look at this and said, do we really need to make all of those measurements? Can we find a more efficient way to systematically measure drug combinations? So I'm going to just do a little bit of geometry here. What I show you here are 3 checkerboard assays. It's an illustration, one where it's additive, so it's the straight contour, one it's synergistic, so it's concave, and the antagonistic one is convex. You see that, right? All right. So if I only want to quantify the shape of the contour, what we realized is that you don't need to survey the whole space. I don't need, in this case, a whole survey. I only need certain pieces. So what we did instead is to pull the most information-rich parts of this grid in order to estimate the shape of the contour. So the way we do this is to measure the dose response of each single drug. Those are on the axes. And then we go straight across the diagonal in the middle. So that's a combination drug dose response of the 2 drugs that we're looking at. And what we can do is just simply look at the intersection here. So if it's an additive behavior, then we draw a straight line between, this could be, whatever phenotype I'm looking at, draw a straight line, and where it intersects with the diagonal, which I also measured, is the expected behavior if the drugs are additive. If it's concave and they're synergistic, then the actual value is going to be smaller than expected value, and if it's antagonistic, it's going to be greater than that value. So in making many fewer measurements, we can get almost the same amount of information as that huge massive experiment that we avoided doing before. So this is a way that we can really efficiently and systematically measure drug interactions. So we've been doing this methodically in TB, and we're doing this so that we can start to really rationally design improved drug combinations for TB and other infectious diseases. And one thing I'm just going to leave you with is the idea that this method is not specific to 2-way interactions. We can go up to N-way. In our lab, we've done up to 10-way interactions now. Instead of projecting against a line, we just use a plane. So we just have to visualize in multiple dimensions. And as I said, we're systematically doing this in TB, looking at combinations of 20 drugs together. So I think that the idea of bringing systematic approaches into the lab to study drug combinations is a really underutilized tool that we have in our toolkit, and one that we're working on very hard at Tufts to see if we can not only better use the drugs we have, but protect the new drugs coming on the market to make sure that they're used in the most effective way possible and kind of stave off the acquisition of drug resistance to those new molecules. So, thanks.
Thank you. So I think you can see that there's really a breadth of expertise that we have, and this is just a sampling of the type of work that's relevant to antimicrobial resistance. And so I thought I'd just very briefly mention that on the basis of this type of work, the school has invested $750,000 in the Center for Integrated Management of Antimicrobial Resistance, or we call it CIMAR. And it's going to be led by Helen Boucher and Ralph Isberg at the medical school, and myself. So I won't go through this in any great detail. I think you've sort of seen that there's several priority areas that we need to address this complex problem of antimicrobial resistance, emergence, policy and stewardship, and then new therapeutics. And the thing that I will say is that we have at Tufts quite a bit of the pieces, I think, in order to address this in a comprehensive fashion. So we have genetics and microbiology. We have infection models, especially at the vet school. There's a chemistry department. We understand pharmacology. And then we're affiliated with Tufts Medical Center, where we can do clinical testing. And so I just will here fill in various institutions and schools at Tufts, which really are the home of much of this expertise. And so we are going to take a very broad look at all of these activities. We're going to try to make help people collaborate. We're going to generate new educational programs. And we're going to have a seminar series, an annual retreat, so that people sort of run into each other and able to discuss with each other on sort of an informal basis. And of course, we need to make industry interactions because our ultimate goal is to be able to improve diagnostics and improve treatment, and of course, be able to use some of those funding sources to be able to further our research. And so we have a two-phase timeline. In the first phase, we want to invest in both research and education, and the idea is to really emerge as a national leader, and through any number of initiatives. And then in the second phase, 3 to 5, we hope to grow into an international leader in this field. And the idea is now to be able to bring together a number of investigators, both involved in education and involved in research, to be able to apply for external funding and be able to make partnerships with pharma, and then use some of this funding to be able to invest back into this center so that it becomes a self-sustaining mission. So why don't I stop there? I'm hoping that there's questions. We certainly welcome your questions, and please.
This is a great panel. Thank you. Very, very interesting. And excuse my ignorance on this point, but what's the cause of this? I mean, where does it come from, and why does it continue to grow?
Yeah, so it's a great question. So since before people were on the planet, there was antibacterial resistance. So bacteria becoming resistant is a natural part of what they do. The crisis that we face is an acceleration of natural resistance, and that's occurred largely from overuse of antibiotics in people, animals, and the environment, as well as other factors, potentially even external factors like global warming. You know, there's a number of things that have come into this. I think the factors that we're the most focused on are the overuse of antibiotics, especially in humans and animals. One thing I'll just come back to as a takeoff on that, Amy's talk about antibiotics in the third world, that issue is very complicated, right? So many experts talk about antibiotics being used as a surrogate for clean water in developing countries. And without more work from Amy's group and others, that proof is still lacking. So at the global level, one of the biggest problems in the developing world is access to antibiotics. And so the World Health Organization and others are very focused on having access to antibiotics as a way to prevent neonatal mortality, which is a huge issue. So as we think about our efforts in things like stewardship and other areas, we have to be mindful of this need for access to antibiotics in the developing world, which is we don't think about here, right, because everybody can get antibiotics. So Amy's work and other work on infrastructure is very, very important. And so we have a national action plan for combating antibiotic resistance in the U.S., and there is a global action plan that came out of that UN meeting I mentioned. We're having the second review of that. It's actually happening in Ghana in a few weeks, where the individual countries are going to report back on what progress they've made on their own national action plans with things like access to clean water, vaccines, and other things that are really important. But to circle back to your question, it's an innate characteristic of bacteria to develop resistance. It's been accelerated since the dawn of antibiotics in the 30s. Anybody else want to add?
Okay. So thank you very much for this very illuminating and excellent presentation. I have a two-part question. One was you were saying stock prices on antibiotics are going down. I'm wondering, is that because because antibiotics are more cheaply available or a lack of interest? That's the first part of the question. Second is just about the national security risk, and I'm wondering whether you and organizations that are working on AMR are working with the Department of Defense and universities around the world, because this is, a biological weapon, essentially, right? The creation of AMR. So it is, you've talked about it being a crisis, and I think about it as really a massive security crisis with AMR. So kind of two-part question.
Excellent questions. So first, the economic issue. So antibiotics are drugs that are used for very limited periods of time, and that are also held in reserve by people like me, experts, right, who say, get us these new antibiotics, but I never want to use them because I want to have them for my patient when they get the resistant infection. So that leads to a very small market. And they cost, on average, $1 billion to develop over a 10-year period. And that work has come out of the Tufts Center for Drug Development. They're the leaders in that kind of research. So going back 10 years, big pharma started to leave the antibiotic space because in a big pharma company, they have to answer to their shareholders. And so if you tell the shareholders that it takes $1 billion to develop an antibiotic that's going to have annual sales of a couple $100 million versus an obesity drug, a cancer drug, an anti-smoking drug that's going to have many billions, that's not good fiduciary management to the shareholders. So big pharma exited. Then the development went to small biotechs. And for a while, the small biotechs found a model that could be workable, whereby a biotech could develop an antibiotic and have a reasonable return, usually by getting partnered by a bigger company once they're to the market stage. But more recently, it's gotten even worse. And so the so-called market failure that a lot of us talk about has gotten worse. So we and others have been very vocal about this in Washington and other places. And Lord Jim O'Neill in the UK wrote this report, the AMR Review. He's an economist. He used to work at Goldman Sachs. He made the economic argument that something needs to be done to incentivize antibiotics. So out of that has come a big body of work on both sides of the Atlantic that has led to this concept of incentives. So push incentives that are incentives to get things into the people testing, like my world, and then so-called pull incentives to keep things on the market. We don't have a pull incentive today. We're working hard on one, and I'm involved in a group headed by the Duke Margolis Foundation and the Wellcome Trust with the goal of coming up with a tractable pull incentive within the next 18 months. And many people would say it needs to be sooner because these companies are going out of business. And if a company that has a marketed drug goes out of business, that means we won't have that drug for our patients. So the drug that got approved could not be available for our patients, and that's really scary to me as a doc. So let me come back to the push incentives. So the push incentives were addressed first, and they were addressed largely through, most successfully, I would say, through a public-private partnership with the government and with the Department of Defense through BARDA, the Biomedical Research and Defense Authority. So there is an entity called CARB-X, which is a public-private partnership funded largely by our government and BARDA, the Wellcome Trust, and a number of academic entities that will fund over $500 million to the development of antibiotics and diagnostics in the next several years. Out of CARB-X have already come several approved antibiotics. So it's an effective push mechanism, and we're very grateful. The Department of Defense is very active in this area, and we have, even with the changes of administration, we still have good support. One of the hats I wear is a voting member of the Presidential Advisory Committee for Combating Antibiotic Resistance, and that's where we interact directly with the government on these issues. And the Secretary of HHS is very, very tuned in to this problem, and we have great support in that regard. So I think we can all be comfortable that the Department of Defense is engaged. We still have a lot of work to do, and I think that the sort of prevailing wisdom today is that the concern is that all this push will lead to compounds that are ready to be tested in patients that won't advance. And so we need that pull incentive to come through so that that advance will happen. So did that address both issues? Okay, sure.
Hi, I'm curious if you can speak a little bit about what policies would you like to see U.S. policymakers proposing to support the global health, the global issue?
Okay, so great question about what policies are we sort of most engaged with. So we've been involved with policy on a number of issues. So one issue was the designation of these priority pathogens. So in that CDC report, there was a designation of priority pathogens. That process is happening again, so we'll have another report in 2019. Very important. And the WHO has a similar process, so we've been involved in that policy. We've been involved in policy about how antibiotics are developed. So what does it take? What kind of studies, how many patients to get antibiotics through FDA approval? So we were involved in a thing called the GAIN Act, which had to do with designating certain products as qualified infectious disease products if they addressed these certain bad infections and unmet needs. We were involved in the 21st Century Cures Act, which led to this limited population antibiotic development, or LPAD pathway, which is a pathway to approve an antibiotic for the most serious unmet medical need. We're now involved in legislation for these pull incentives that I mentioned. So we have a number of different sort of areas.
I just had a quick question. I'm just wondering, I've been just coming across more and more articles about fecal transplants as a way of kind of working with things like C. diff, and then looking at articles that are talking about remedying pig gut. And I'm just wondering, given the center that's being launched and the relationship between the environment, animals, and people, whether or not tapping another element of expertise in the Tufts community, namely the veterinary school, could be brought to bear on the new center, et cetera.
So great question. C. diff was discovered at Tufts. And fecal transplants are being studied actually by members of our group already. And the whole world of the microbiome, so the bacteria that live in our gut, understanding them and their good jobs and their maybe not so good jobs, is an area of great research that's already underway. There is a collaboration with the medical school and the vet school looking at the microbiome, and we in the medical center have a group who's doing some very interesting work looking at antibiotic resistance in the microbiome of long-term care facility like nursing home residents. It turns out that that is a population of huge antibiotic resistance. So could it be that fecal transplant to a nursing home resident would decrease their resistance so they wouldn't come back like my first lady with the multidrug-resistant infection? So that is an area of great interest.
So I just want to add to that. In our studies in China, we actually get samples of the complete microbiome. And so one of the reasons why we think there are differences between men and women in expression of antimicrobial resistance genes is because of the microbiome of the female genital tract versus the males. And so we actually have all that information, and we are studying that. And I should also say that the HNRCA, are you all familiar with the HNRCA, also does a lot of work on the microbiome. So we definitely have strength at Tufts.
Hi, Jennifer Covell, class of '86. I happen to be married to a marine biologist. And one thing that I've been hearing since my kids were born, this proliferation of hand sanitizer, is that contributing to this problem at all? And can you speak to that?
Sure, it's a great question. So hand sanitizer and AMR. So I can tell you what I know as a clinician in infectious diseases. Hand sanitizer has been proven to be as effective as hand washing if it's done correctly. So hand sanitizer, you use it, you rub it till your hands are dry. Hand washing, you sing happy birthday 3 times, right? So you have to do it for 15 to 30 seconds for it to be effective. So in a busy hospital or doctor's office, hand sanitizer is by far the most effective from an infection prevention standpoint, from preventing transmission of infection from patient to patient, from healthcare worker to patient. And that's been extremely well studied. So there are other data that suggest that the components of hand sanitizer are linked to resistance. And I think that's where it gets more interesting potentially in terms of the kind of ecologic effects and the larger effects on AMR, and I think that's still an evolving area. I'm not aware of anything definitive that has risen to the level to say, like, we shouldn't be using hand sanitizer.
Well, I just wanted to add to that because I've actually done some work on hand sanitizer in low-income countries where piped water is not easily accessible, and so hand sanitizer provides a waterless method of cleaning your hands. And there's 2 types of hand sanitizer. There's hand sanitizers that just have alcohol in them, and so disinfect your hands that way. And then there are hand sanitizers that have antimicrobial compounds added into them. So the use of that type of hand sanitizer can foster antimicrobial resistance, whereas alcohol, pure alcohol hand sanitizers do not. And so I think there's the same issue with soap, and there's been national guidelines that have come out recently saying that antimicrobial soap is not necessary, and that using soap, just normal soap, is actually just as effective as antimicrobial soap.
So I see another question. I'm sorry, we've got to cut this short, but please come up and ask questions. We're happy to have individual discussions with you. So thank you very much. Thanks for your attention.